Thank you, Dr. Abbey, for joining us. It's good to see you, Ash. Thanks for being here.
You too. Thanks for having me.
So we wanted to talk a little bit about the recent treatment advances for geographic atrophy, and some of the most recent data on that. So perhaps you could give us some of your, broad overview perspective on where we stand.
Yeah, I mean, we've really had a fundamental shift in treatment for GA over the last 2 years or so. For the first time, we actually have agents that we can use to actually treat to consistently slow the lesion progression. Those two agents that got FDA approval were pegcetacoplan, which is Syfovre, and also avacincaptad pegol, which is Izervay. They both actually showed consistent slowing of lesion progression in their phase 3 randomized clinical trials compared to sham. But now we really have a lot more long-term data from both of these agents. They have long-term extension data that has been published for about 4 years for Izervay and for 5 years now for Syfovre. One of the highlights of the 5 year, what we call the Gale extension study for Syfovre, was that there was a cumulative delay in GA progression of about 1.5 years compared to a modeled natural history for patients who would not be receiving treatment. They also showed, and this has been consistent with both of the phase 3 trial or both of the agents that we're using right now, that they have an increasing effect over time in terms of slowing the lesion progression. Over the longer course of time that you use these agents, we do see more of a treatment effect, more of a slowing of the rate of growth of GA. Also, in these long-term trials, everybody was concerned about safety, and in both the Izervay trial and also in the Syfovre trial, there was a pretty good safety profile overall. We have had some concerns with respect to vasculitis in patients, specifically with patients who receive Syfovre. What we've run that down to is it's usually a first injection phenomenon, and it's about 1 in about 4,000 first injections will get kind of a more significant inflammatory episode. We haven't really seen that, though, in any of their trials. It's really only in real world situations where we've seen that. So in the hundreds of patients that were treated in the clinical trials, we've not actually seen a case of vasculitis with either agent.
Awesome. Yeah, yeah. Thank you for that. It's encouraging to see some of the anatomic benefits, the cumulative benefits that kind of compound over time. Certainly, that's some promising data, encouraging data that's been out from the trials. In terms of other endpoints, functional endpoints that we often think about visual acuity or some of the other functional things like reading independence. How do you talk about those types of endpoints and the data from the studies with your patients in terms of those considerations?
Yeah, in terms of the study data, we did not actually see with either trial, we didn't see an actual change in terms of visual acuity loss for either the sham group or the treatment groups for these phase 3 trials. But I think that doesn't really give us the whole picture when it comes to visual outcomes for patients with GA. I think vision is much more complicated in a GA patient, and I think you can't really look at it just solely from best corrected visual acuity, ETRS readings, and things like that. Reading a chart versus just functional vision in a GA patient, I think, is very different. And so we do have to pivot more so in all of our GA trials going forward, I think, in focusing in other measures of visual acuity, like using microperimetry data, using data from low luminance visual acuity changes. Also, just in terms of just any sort of other changes that we can think about with respect to functional vision and measuring it in different ways that would be more accurate to a patient who has GA. Because you can have a GA patient who is 20/25, but if you ask them, they can read the chart 20/25 if they move their eye around. But if they have a fovea, maybe a budding lesion of GA, a lot of times they have to kind of shift around and find those letters. And when they actually try to read on their own independently, they oftentimes struggle greatly because they're missing letters within words and things like that. So they have a much harder time actually reading. Their reading speed declines. They get much more frustrated, maybe fatigued by reading. we just really have to not be as simplistic when it comes to our outcomes or our endpoints in these clinical trials, and also in the way that we assess our patients as well when it comes to looking at just, Snellen or ETRS visual acuity readings. We have to look at other things that can kind of give us a more fuller picture of what functional vision is like for these patients and how we can measure that for them. Having said that, there is now at least some data, particularly out of the Gale study now, where they were able to show that the number of microperimetry lesions that were actually lost over time with treatment with pegcetacoplan or Syfovre, there was actually a statistically significant reduction in lost points on microperimetry in patients who received Syfovre compared to sham at 3 years in the Gale data. So that was for the first time, at least in these data sets, showing something where there was an endpoint that was actually set for the trial, an actual significant reduction or significant, let's say, maintenance of vision compared to sham in that group. So it's not, it's not best corrected visual acuity, but it is something that at least can give
Yeah.
us functional out.
I'm with you there. We need to have a holistic view on what we consider to be functional vision. It can't just be visual acuity, but we also have to think about other aspects of vision, such as their reading speed, their ability to see in low light levels, and other paracentral microperimetry data is certainly helpful. Interesting to see as we have more longitudinal data from these trials, how this kind of functional impacts, functional data can be impacted over time.